So I'm sure you all remember that the first of the principles of statistical quality is relevance. If you don't remember that, then just pretend to. And so I always start with, well, what are we actually doing this for? And a general summary would be, we want to ensure that people who have long-term impairments are treated equitably in society and by our government organisations and so on, and to try and remove the barriers that exist to participation in society. You'll notice that I'm choosing my words carefully here. I've not used the word disabled, because of course if you remove the barriers, then those people with impairments are not disabled. And that's one of the implications of the whole kind of ICF theory and the way the definition works about the interaction between the impairment and the barrier. We need statistics to identify needs, to support and monitor the provision of services, and more generally to understand the proportions of disabled people, the prevalence, if you like, bearing in mind everything Jennifer's just said about prevalence, and the types of disadvantage that people face and the consequences of those. So, no?
It's the bottom right.
So you all know the kind of basic definitions which everyone's been talking about. I'm going to put in a very legalistic one as well, and that's from the point of view of UK official statistics, the most important one, and that's the definition of the Equalities Act, which in legalistic language says that a person has a disability if they have a physical or mental impairment which has substantial long-term adverse effect on their day-to-day activities. So if you look at that, it's a little bit what people call medical model because it's focusing on the impairment rather than on the barriers. If you look on the other side of the slide, we've got the UN Convention. It's got rather similar words, of course, long-term physical, mental, intellectual, or sensory impairments, hindering full and effective participation. So that's more on what you might call the social model because it's focusing on the barriers to participation rather than on the impairment. But it's got pretty well the same basic ingredients there. It's got some kind of impairment of various different kinds. It's got a long-termness or permanence to it. It's not just that your leg's in plaster for a week. And it's got something about restricting your ability to take part in society and to live your life. Now, you could divide the approach to asking questions into two general schools of thought. One of them is what's sometimes called the Global Activity Limitation Indicator, or GALI type of question. And that doesn't focus on what's the specific type of impairment or the specific functioning that we're talking about. It just tries to find out, is there some kind of impairment which is causing a restriction in participation? Now that has some benefits. Firstly, it's pretty quick to ask. Quite importantly, it's not limited by any particular kind of impairment. And from the point of view of both the equalities legislation and the convention, we don't really think we should be restricting the population of people who are defined as being disabled by some kind of preset list. Or we think that people should be able, whatever their kind of impairment, to declare themselves in effect to be in that category. So one of the good things about this galley type question is that it doesn't put people in a limited set of categories. On the other hand, you come out without any impairment specific information. You know X number of people are disabled, but you don't know how many of them have got mobility issues, how many of them got vision issues, and so on. From the point of view of basic disaggregation, that may not matter, but from the point of view of useful information, for example, for planning of services or other things, it may be very important. On the other hand, you've got something which you might call impairment specific or health condition specific or function specific. There's lots of different ways you can look at it, which is where you start with some kind of list of specific impairments or functional domains. It may be a short list, as in the Washington Group short set, or it may be a much longer list. The basic concept is again similar, that there must be some restriction of activity or participation connected with that impairment. The downsides of it, firstly, it tends to need more question time and space. And there are kind of disagreements and complexities about the concepts of the different domains, and are we going to talk about functions, are we going to base it on impairments or what? And it may predefine or limit the categories that allow people to actually identify themselves as being disabled. But on the other hand, it's very objective. It doesn't allow vagueness. You know, either you do or you don't have a restriction on mobility, a restriction on vision, and so on. And it gives you useful information, of course, about the types of impairments and functions. In UK official statistics, we have various sources of information that you may have come across. Obviously, there's the census. There's the Life Opportunities Survey, which ran for quite a number of years, unfortunately doesn't at the moment. But, excuse me, I'm just going to drink some water. The Life Opportunities Survey, it wasn't a huge survey, a sample of only about 20,000, but it was very detailed about disability and barriers and limitations and so on. And then, of course, we have the much bigger surveys like the Labour Force Survey, the Family Resources Survey, which run regularly, which do collect information, but not quite as much. We also have the National Health Surveys of England and of the devolved administrations, and incidentally also the European Health Interview Survey. What I haven't mentioned here, of course, is all the administrative data sources as well. There are numerous data sources where people are asked as part of, it could be signing up for some government service, enrolling as a student, attending a healthcare or whatever, you know, where the disability status is measured by one question or another. I thought I'd better put some statistics in, otherwise it would be a bit boring. Here's some recent figures which are taken from the 2016-17 Family Resources Survey. And they show actually what pretty well every data source shows, which is that overall there's around 20% of the UK population reporting having disability. And obviously that's higher among the elderly, it's lower among younger people, and so on. Whatever survey you use and whatever wording you use, because there are different variations in many of the questions, actually you tend to come out with pretty well that figure. This is from the same data source, and it's showing different impairment types or functioning types or whatever we're going to call them at the moment. As you'd expect, the highest is mobility. Interestingly, stamina, breathing or fatigue comes next, and that's not always included in the standard lists. As someone who suffers from chronic asthma, I think it certainly should be included quite often. I certainly find it restricting at times. And then we have the usual things, hearing, vision, and so on. That gives you some perspective on the UK distribution of those impairment categories. So one of the problems we have, and I would say at this point in UK statistics, we're very much in a could do better situation on statistics about disability. One of the problems we have is that we have lots of slightly different questions in different surveys and different data collections. We produced a harmonised question set in 2011, unfortunately too late to go into the 2011 census, which was very thoroughly validated and involved a lot of consultation, not only across government, but with disabled people's organisations and others. And it asks 3 quite simple questions, and they're not so complex that people, as Jennifer says, they're kind of fallen asleep by the time you get to the end of the question, which is, I guess, partly a result of the cognitive testing and the consultation we did. Do you have a physical or mental health condition or illness, blah, blah, lasting or expected to last 12 months or more? Why 12 months or more, you may ask? Well, all the definitions require that the disability should be something long-term. How do we know it's long-term? Unless we ask. And the definition of 12 months comes from the Equalities Act. Does your condition, illness, etc., reduce your ability to carry out day-to-day activities? Again, it's a simple question. It's not going into exactly how. It's just finding out, does it or doesn't it? And there you have, in effect, your Equalities Act definition of disability. Answer yes, and you've identified yourself as disabled. And that can be used in disability disaggregation and to ensure that people are getting their proper rights to equality. There's another element which says, how long has your ability to carry out day-to-day activities been reduced? And again, what you may say, why 6 months? What exactly is going on here? So we're getting into a bit of history and kind of complexity here. Don't try to read that. It comes from the instruction manual. What's actually going on here is that with these 3 questions, we're meeting lots of different needs while doing it with some quite simple questions. We're seeing whether the person meets the Equalities Act definition. We're also drawing a straight line to the historical question that's been used in lots of surveys about limiting long-term illness. We're also seeing whether they meet the European Union survey definition, which uses 6 months as its definition of long-term, not 12 months. So when you put all these together, you actually get lots of different bits of information depending on the combination, and that's partly why it looks like that. There is also a harmonized question set which goes into specific types of functioning or activity, or whatever we want to call them. Some of the, again, we have in different surveys, which isn't terribly satisfactory. This is the 2011 harmonized set. But in fact, some surveys really, you can see they're focusing on physical impairment. Others, they're focusing on functioning. It all depends. This one asks, and you can say, yes, a little, less, a lot, not at all, to each of these, depending on the format. So the obvious things: vision, hearing, mobility, dexterity, and so on. Mental health, fatigue, social or behavioural issues, others. This list is quite important in a number of ways. One of the points about it is it does include mental health and intellectual disabilities or psychosocial functioning. We consider that important. I completely take the point, which Jennifer has already mentioned, that these are difficult things to question, and particularly across languages and cultures. So I wouldn't necessarily expect other countries to ask about them in the same way, but we consider it important in the UK that we should. There's also other. Please specify. As I said, it's part of the conceptual definition and part of the idea of the rights of disabled people, that it should be possible to, in effect, label your own disability and not be pushed into a specific medical category or functional category if that's not what applies to you. I was asked for the purposes of this session to actually focus particularly on the kind of international different comparison of the Washington Group, that kind of thing. I'm only talking here about the Washington Group short set because that's the kind of widely used international version, and I completely recognize there's more in the other tools. So don't shout at me about that. But this is quite interesting. What is or isn't there in the UK harmonised version? For example, we explicitly ask about how long is long term? Is it a long term thing? We specifically separate out, do you have a health condition or impairment, whether or not you are restricted by it? Obviously, they both ask about severity, which is very important, using slightly different words. When you kind of look across the domains, the obvious ones are obvious, and they're in every question set, whether it's the Washington Group, the UN, ours, whatever, vision, hearing, mobility. On the other hand, there are some things which are in our question set where we go, because we've gone into more detail, we've not made it as short, like mental health, stamina, things like autistic spectrum, intellectual disabilities that are there, which wouldn't be in the Washington Group short set, but I think would be in some of the tools being developed. So, I mean, I'm not trying to go into some kind of competition and say one's better than the other, but it gives you an idea of some of the differences. It also gives you an idea, because sometimes people say to us, well, the Washington Group is the international standard, why don't you use it? And one of the reasons, it's not the only one, because there's also continuity of time series and so on, but one of the major reasons is because mental health and intellectual disabilities. This is taken from the Life Opportunities Survey. It's slightly old data, but because it was a very specialised, detailed, disability-focused survey, it's still useful. One of the things that's most striking is that when you actually bring pain into the definition as something people can use to define their disability, it actually comes up more often than anything else. And I think that's very interesting, because it's not usually included. And then we have all the usual things. Mobility comes next. The writing's too small for me to see here. You'll notice, if you're eagle-eyed, that some of those have got an asterisk. Some of those little headings have got an asterisk against them. Mobility, sight, hearing, memory, learning, communication. Those are the ones that are in the Washington Group short set. And obviously, it was a very detailed survey, and it also included quite a few other categories. This is another view of the same data. And what this is doing is dividing it. The dark bar at the bottom is the people who reported only that one. The light bar is the people who reported that one and other things. So there's a lot of overlap and multiple functions. The grey bar here is everyone who said, I have a disability. Not those words, but the one I showed you earlier. Not everyone who actually signed up to having a disability actually ticked any box for any specific functional category. And of course, when you divide it, and what we've got here in the rest of the graph, into Washington Group short set versus anything else, you find the gap gets bigger because the Washington Group short set contains only 6 categories. So what this is showing us is, again, if we cut our question down, if you like, to only those people who say yes to specific categories, we'd actually be missing out on a chunk of people who identify themselves as having a disability. Anyway, where are we going now? As I said, we're at the moment, we are at a kind of could do better situation. We've got quite a lot of data. We've got quite a lot of data, interesting enough, that we haven't used. And we need to start using it more. And I'll give you 3 headings. Improve within UK coherence. That's very statistically policy-ish. Making more use, if we can, of that harmonised disability question set to try and get more consistent results and better results in our different data sources. Get data from the 2021 census, which uses similar concepts so it's more comparable with what we get from surveys. Improve international comparability. We're prioritising the Sustainable Development Goals data gaps for disability disaggregation as our kind of leading way into it. And that was 64 out of 114 possible indicators where there were data gaps relating to disability disaggregation. So that's one of the priorities that we're going to be working on. Engaging with the Washington Group. We've actually not really been engaged with the Washington Group for a number of years, unfortunately. And we are going to rectify that and get back into kind of constructive discussions internationally. And finally, and this is very much in line with ONS's and the Government Statistical Service's overall policy direction at the moment, leveraging new data sources, compiling information from existing administrative data, which is there but isn't really being used for statistical purposes. And bringing a lot of data together, linking data from, let's say, the census, other administrative sources, surveys, and longitudinal analysis, so that we don't necessarily need to ask more and more questions all the time, but we can actually pull data together in order to get the right answers. So there are a few of the things I've mentioned. There are some links. That's me at the top, and I've also given you there the details of my colleague Claudia Wells, who's in charge of our Sustainable Development Goals development. Thank you.
World Health Organization and World Washington Group questions. How do you control for expectations that may differ within a country and definitely between countries? This is to do with the different levels of expectations about the topic. So maybe if I ask...
do we need to... Are there people still listening?
I think there's still people listening, so we'll sort of pass this around. So maybe we'll get questions out, then we'll take a few comments from the floor and we'll come back to the speakers. So get your questions ready. So,
yeah, I would say dialogue with the countries. So it's, I think, I always say it's hard work, dialogue, spending time, and trying to bring everyone involved and for whom the data is relevant on the same table and discuss. We are, from the WHO perspective, we are also a member state and Ministry of Health driven organizations, and that also drive our commitments. So in this sense, when member states sign in our resolutions and in our action plans, that is a very powerful tool then to start the discussions when we are in the countries and they request, ministries request our support in countries.
Okay.
Thank you.
Jennifer.
Yeah. I'm not quite sure what kind of expectations are being referred to, but because we are a group of countries, I've been discussing expectations about this for a long time. We also do, with the funding that we've gotten from the Government of Australia, we do a lot of workshops, regional workshops. We sometimes go to individual countries. We have annual meetings. So what we're trying, there's a lot of discussion about what we're trying to do, what you will get out of this, how to use it, where there might be gaps, and how to fill those gaps. I think there's this, we went from a time when there was this impression that the population with functional limitations or disability, whatever you want to call it, was very small. That was not appropriate. So there seems to say, what is the right? There is no right number, but there are probably wrong numbers. And usually the wrong numbers are because your methodology. So we tried to say that you can't go into the data collection saying, if I don't get X percent, it's wrong. You have to understand how you're collecting the data. We always tell countries, what's your age distribution? Do not compare yourself to a country that has an old age distribution, because if you don't age adjust, you're going to get all kinds of junk. But I think it's as Alako says, it's a lot of discussion, it's a lot of working with countries, and that's part of what we have done jointly. We are part of the Secretariat, and I should have said that. I have colleagues here who are from the Secretariat. So we kind of do the administrative part of the Washington group and often talk on behalf of them. But basically, we are our own expectations.
Okay. Do you want to react?
Yeah, I'm not sure if I need to answer this one unless by expectations you're talking about the difference between England and Scotland, and that's probably not what the question meant by countries. I do think it's a fascinating area, and I mean I wonder when I look at a question like do you have difficulty washing yourself? It's not about expectations but about circumstances. If the water comes out of a tap or if you have to walk a mile to a well for it, what's the effect of that? But I think I would go back to what Jennifer said about there's no such thing as the right prevalence. It's all relative.
Okay, and there's a little bit of clarification from the question there about expectations as reflecting respondents' expectations. For example, what good health means, what limitation means, especially with growing age populations.
Did you want to?
No.
Maybe what I'd like to do now is throw the floor open. So I'm going to take a range of comments as quick
And then we can
comments
answer
or
them all.
questions, and then we'll give each of the panelists a sort of final word. And after I got some comments and reactions within the room, I'm going to go outside in case there's some people still tuned in and engaged, and offer them an opportunity. So would you like to go first? Maybe introduce yourself and then...
I'm Madhuri Bajegal from UCL, and I've been working in OLS for some time, but I'm not at UCL. Fascinating subject and really difficult topic to get any sort of statistics on. I'd be interested in the panel's view in terms of, okay, so now you've got the questions, you put them in lots of senses and surveys, you've got the cross-sectional estimates, and your intention is to influence policy. But once you do influence policy and they remove barriers or the constraints, how do you measure change in this sort of shifting environment where social norms are changing, expectations, that is, of what is a disability, technology is changing, making things, the assistive devices more readily usable. What are your thoughts on how do you measure change, not only in terms of policy evaluation, but real actual population change in disability prevalence?
Okay, thank you. We'll hold that question. And are there other people who'd like to come in the room?
Yeah, we have.
Matthew.
Okay, sorry, it's another question. The stuff about exactly what questions you ask is very interesting, but for a lot of developing countries, I think there's a sort of prior question, which is, do I need, can I just put some questions in the surveys which we're running anyway, like the DHS and the MIX and the Living Standards Measurement Survey, or do I need a special instrument or a special mechanism for disability? And I picked up that, I would say, Jennifer seemed to be suggesting that you can get away with a normal 35,000 household survey and just put some questions in there and that will do. Whereas something like the Life Opportunities Survey, you have a screening question and you're trying to deliberately trying to target the disabled. And so I'd like to hear about which approach you think is necessary.
Okay. I mean, I think there are two approaches that I would want to mention, which are very much part of where we want to get to. One is, do you have a stable time series, which is, you know, methodologically stable, statistically stable? If so, you can see it change. The other one is longitudinal data. If you can identify people who identify disabled, who have specific barriers, and you can see these people becoming less disabled longitudinally, then that would be extremely powerful as evidence.
So there's two things you want to look at change in. One is the basic functional status of the population, and just following cross-sections will tell you that. What % of the population has difficulty along in those domains? What you're looking for in terms of the interaction is, has the differential changed? So yes, there's new technological advances, we've gotten rid of all the barriers, so you may have exactly the same proportion of the population reporting difficulties in whether it's the 6 domains or the 11 domains or however, excuse me, domains you're looking at, but the participation of those people has changed. And that's what you really want to monitor from the point of view of the convention of the SDGs. Now, the longitudinal data is, of course, extremely interesting, but very expensive. Linkage is wonderful, and that's easier to do. But to answer the policy question, really, you just need the repeat cross-sections with consistent data. Now, whether you do a targeted survey or whether you embed, even if you're going to do a targeted survey, you have to identify the population, and so you have to have a population-based survey unless you're going to use administrative records, and administrative records have their own issues in that they tend to be based on self-selection and all those things. So we did a big disability survey in the US in a year I don't remember, ran for 2 years, and we had a 20-minute screener on that survey. And after we did it, we said, we're never doing that again. That we get better, more policy-relevant information, but we still need to identify the functional status of the population, which we can do. Now remember, the set of questions we developed, whether it's the short set enhanced, which gets at your psychosocial and other, and the extended, are to embed another survey. So now you say, well, now I'm doing a disability. I want to do more on disability. I start with those sets, and I add to it. I add more detail, so our extended set has much more detail on all of the domains we're asking about, the new domains, which include pain, fatigue, anxiety, depression, and upper body, some of the interactions, you put in the barriers, you put in the facilitators, and then you get the more detail. How often do you have to do that? Probably not every year, but you may want to monitor every year. And so you want to do a mix of that. 35,000 will not let you do a lot of intersectionality, as we say, but it will allow you to do some. And many of the surveys, again, in the developed world, our surveys are continuous. The labor force surveys are kind of always going on. It's not like you do it every 10 years. We combine years of data. But what I think the basic point of the international standard is it can be used in every survey. And you may not, some of the questions that we might ask in the US, which are similar actually to some of the GALI, they don't work internationally because of the expectations. And that's, I think, gets to this topic where what are their expectations? We don't ask about things that vary, the expectations vary. When we did the testing, when we say, do you have difficulty? Everybody was interpreting difficulty the same way. That's why we don't ask about day-to-day activities, because they vary. I'm sorry,
okay.
You said you need to go.
Marcus is going to answer this question, but then there's an additional question being put in online. So we're going to add this in. I'll ask Alarcus to respond to that as well. And then very quickly I'll ask Jennifer and Myers to give a very final response. But the question is very specific. So the one for Myers is interesting to hear about the UK not being as good, and to see how the UK and Washington group questions compare. So the question for Myers is, what plans are there to test the Washington group questions in the UK? And the question that Alarcus is going to answer now, as well as the questions we've had, is any plans to test the Washington group and the Model Disability Survey questions against each other?
Mm-hmm. So in terms of the question that was posed before, I think from our perspective is you will only understand what really is associated to the change if you collect information on how people conduct their lives. Is that associated to a change on health and health state, or it is this associated to a change on the environment? And if you have longitudinal data on this component, you will be able to tussle it out based on analysis. So from our perspective, and we have in some cases some longitudinal data where you can puzzle out in a very nice way. In terms of the head-to-head comparison, there are some interesting analyses and results that have not been put in the public domain. Some are, I think, 1 or 2 papers are out there, but not really in the public domain.
Okay, thank you.
Right. No, I must say, or I'll be in trouble when I get back to the office, I wouldn't say that the UK isn't good. I would say that we have quite a lot of gaps and quite a lot of work still to do to fill those gaps. On the testing Washington group and the UK questions, our first port of call is to look at existing data and see if we can clearly identify, in effect, which respondents would have been identified with disabilities using specifically Washington group questions as opposed to using the questions we did. If that proves unfeasible, for example, because some domains don't clearly, or questions don't clearly relate to each other, then we will have to think about actually running some extra questions in a survey to do head-to-head comparisons. We're reluctant to do that simply because of the costs of and burdens on respondents of doing it.
Thank you.
Yeah, I think that because we also have the extended set on the US survey, which does have some of the same domains that aren't in the short set that are in the UK, we can do some analyses internally that, it's not a direct comparison, but it does show who would have been missed, how many would have been missed in those other domains. And we have actually done that to a large extent, particularly around the psychosocial functioning. We can have long discussions about whether fatigue is a functional domain and how do you deal with it, but we do have questions about fatigue and pain on the extended set. So the Australians did something very similar. They actually had an ongoing survey. They added the 6 questions, and then they did a lot of joint analyses. It was very similar because a lot of their questions were coming from that interaction point of view. And there used to be some questions in the US that were similar, that we've done our comparisons. So I think that we had a conversation about this morning. We are trying to describe the population. We're not trying to identify every person in the population who might have a disability. We want to get an overall population. We'll have some measurement error. The question is, what's the impact of that measurement error? And those are things that we can jointly do.